In the next section, I'll discuss labor and delivery, with key concepts of fetal testing, electronic fetal monitoring, physiologic changes before labor, and induction of labor. I've talked about the non-stress test as it pertains to antenatal testing in diabetes, and we're going to go into it a little bit more here. The non-stress test allows for evaluation of fetal well-being in utero and involves two parts: the measurement of fetal heart rate, seen at the top line, and the measurement of uterine contractions using a tachometer, seen on the bottom line. A reactive non-stress test is defined as two accelerations of the fetal heart greater than 15 beats per minute above baseline and lasting for 15 seconds or more when the fetus is beyond 32 weeks. In a fetus that's less than 32 weeks gestation, two accelerations of fetal heart rate greater than 10 beats per minute above baseline and lasting for 10 seconds or more is considered reactive. A reactive non-stress test shows that the fetus is doing well and no further testing is indicated. If the non-stress test is not reassuring and we don't see these fetal heart rate accelerations seen here indicated by the red ovals, the fetus could be sleeping. Vibroacoustic stimulation can be done in order to wake the baby up. Here we see an example of a non-reactive non-stress test. We do see good variability throughout the fetal heart rate shown by the arrows. However, we do not see any distinct accelerations. This could just mean the baby is sleeping and vibroacoustic stimulation can be performed. Another way to assess fetal well-being is the biophysical profile. There are a number of different tests that are done, and if they are present, they receive a score of 2, if absent, a score of 0. The first component is the non-stress test. It is scored as a 0 if it is non-reactive, or a 2 if it is reactive. Fetal breathing is assessed, and if there's an episode of rhythmic breathing for 30 seconds during a 30-minute observation period, it's given a score of 2. Fetal movement is assessed over a 30-minute period of time, and 2 points are given for greater than 3 distinct body or limb movements. Tone is also assessed, and 2 points are given for extension of extremity or the spine with a return to flexion. Finally, the amniotic fluid is assessed. In this case, 2 points is given if an amniotic fluid index greater than 5 centimeters is found, or a maximum vertical pocket greater than 2 centimeters is found. Again, each category is worth 2 points, and a BPP of 8 to 10 is normal, 4 to 8 is inconclusive, and below 4 is distinctly abnormal. To review the components of non-stress tests that you might see on the Step 2 exam, when a woman presents in labor, an external tachometer is placed on the abdomen in order to measure the contractions, seen here with the oval. An external Doppler is placed in order to examine the fetal heart rate. The normal fetal heart rate is shown between the two red bars, between 110 and 160 beats per minute. Bradycardia is defined as below 110 beats per minute, and tachycardia above 160. Fetal heart rate accelerations are defined as an increase in heart rate of 15 or more beats per minute above the heart rate baseline for longer than 15 seconds. Again, if this happens twice, we have a reactive non-stress test. A commonly tested concept on the Step 2 exam are the different types of fetal heart rate decelerations. Early decelerations occur due to a decrease in heart rate that occurs along with contractions. The cause is head compression and a vagal response. Variable decelerations are a decrease in heart rate with return to baseline with no relationship to contractions. They are very sharp in their decrease and return to baseline, and usually represent umbilical cord compression. Late decelerations are dangerous and serious signs, and they occur with a decrease in heart rate after a contraction is started, with no return to baseline or a slow return to baseline after the contraction ends. This represents fetal hypoxia as a result of uteroplacental insufficiency. You may be shown different types of fetal heart tracings on the Step 2 exam and be expected to know what to do next as the next step in management or understand the physiologic process behind the deceleration. We'll review the classic ones here. Early decelerations occur with the onset of contractions and resolve afterwards. Again, these are due to a vagal reaction as a result of compression of the fetal head during contraction. Variable decelerations may or may not have any relation to contractions. They typically represent compression of the umbilical cord. At times, you can treat them with amnio infusions, which replace fluid around the fetus and cushion the umbilical cord. Late decelerations are ominous signs. They occur after the contractions have already subsided and are the result of uteroplacental insufficiency. The answer on the Step 2 exam should be geared towards delivery of the fetus. As we discuss some of the physiologic changes in pregnancy overall, we'll continue by discussing some of the physiologic changes before labor. Some of the early changes include lightening, which is fetal descent into the pelvic brim. The patient perceives that the baby has been lightened. They also may experience a dropping sensation. Braxton Hicks contractions begin, and they do not really result in cervical changes, but the patient does perceive them and may tell you about them. They become more frequently towards the end of pregnancy. Bloody show is blood-tinged mucus from the vagina that's released when the cervix begins to efface and is an early sign of labor. Understanding the different stages of labor is important, similar to understanding the different definitions of the trimesters. The reason being is the next best step in management will be largely dependent on what stage of labor that you're in. Stage 1 is onset of labor to full dilation of the cervix. We expect routine progression of primiparous patients over 6 to 18 hours, while multiparous patients have a shortened first stage of labor of 2 to 10 hours. There's a latent phase, which is the onset of labor to 4 centimeters dilation. Again, primiparous 6 to 7 hours, multiparous 4 to 5 hours. Next is the active phase, which is 4 centimeters dilation to complete dilation. We expect routine progression of about 1.2 centimeters an hour in first-time moms and 1.5 centimeters in moms who have had more than one baby. This becomes important when talking about arrest disorders. Stage 2 is full cervix dilation to delivery of the neonate. Primiparous patients should accomplish this phase in 2 hours, which can be extended to 3 hours if there is regional anesthesia. Multiparous patients are limited to 1 hour, or 2 hours with regional anesthesia. Again, this becomes important when talking about arrest of descent disorders. Stage 3 is delivery of the neonate to delivery of the placenta. This should be 30 minutes in both primiparous and multiparous patients, and can be important when diagnosing placental retention. Monitoring in stage 1 is very specific and should involve maternal blood pressure and pulse monitoring, as well as electronic fetal monitoring the fetal heart rate and contractions as we've discussed. The cervix should be examined roughly every 2 hours. Should be examined for cervical dilation, which can range from 0 to 10 centimeters, which is completely dilated. Cervical effacement, which is the shortening of the cervical canal from a length of about 2 to 4 centimeters to completely thinned out. It's expressed as a percentage of thinning. And finally, fetal station, or where the fetal head is inside the pelvis. The next few diagrams take us through the changes that we would see during stage 1 of labor. We start out with no effacement and no dilation. The cervix is closed and thick. As we progress, the cervix becomes fully effaced and begins to dilate until the dilation reaches 10 centimeters, where the patient is determined to be completely dilated. Station is a description of the relationship between the fetal head and the pelvis. When the fetal head reaches the ischial spines, it is termed zero station. Measurements can be either -3 to +3 station or -5 to +5 station, depending on the algorithm used. Stage 2 is when the cervix has been fully dilated to the time of delivery. We'll use this time to discuss the difference between internal and external fetal monitoring. A depiction of external fetal monitors are shown here. These monitors, both the ultrasound Doppler and the tachometer, are placed on the patient's abdomen and are not placed inside the vagina or uterus. Here we have examples of internal fetal monitors. On the left, we have the fetal scalp electrode, or FSE, and on the right, an intrauterine pressure catheter, or IUPC. The FSE is used when you're having trouble monitoring the fetal heart rate externally. The little screw is placed on the fetal scalp. The intrauterine pressure catheter is an important obstetrical tool and can give information about both the contraction timing and the pressure generated measured in Montevideo units. The external monitors cannot provide anything more than relative timing of contractions. They don't actually measure pressure inside the uterus. This can be important during protracted labor courses. We would expect normal progression with contractions which generate Montevideo units greater than 200. A few more concepts that may show up on the Step 2 exam in terms of Stage 2 of labor involves rupture of amniotic membranes. This can be either spontaneous, so the woman does it herself, or artificial, where we use an amnio hook in order to break the amniotic sac in order to help labor progress. Another concept is that of meconium, or fetal stool, which can be identified during the second stage of labor. If it's identified, it's important to communicate it to the pediatricians, as it places the fetus at risk for meconium aspiration syndrome, which occurs in about 6% of births where meconium is present. Once the cervix is fully dilated, the fetal head begins to descend into the pelvis, and the fetus undergoes the cardinal movements of labor, some of which can overlap. First is engagement, where the fetal head enters the pelvis, typically occiput first. We can then palpate the presenting part in relation to the ischial spines. As we progress, the fetal head descends due to progressive uterine contractions and maternal pushing effort. Descent is going to continue until the fetus is delivered. The fetus will then undergo flexion, which allows for the smallest diameter of the head to pass through the birth canal. If flexion doesn't occur, you can have a brow or face presentation, which can lead to an arrest disorder. The fetus will then undergo internal rotation. When the head reaches the ischial spines, the fetus begins to rotate, and rotation moves the sagittal sutures into the forward position. We then have extension, which occurs as the head reaches the introitus to accommodate the upward curve of the birth canal. Next is external rotation. So during the head delivery, external rotation will occur, giving the shoulders room to descend. The anterior shoulder typically goes under the pubic symphysis first. We then have expulsion. First, there's delivery of the anterior shoulder, which is obtained by gentle downward pressure of the fetal head, which can aid in this delivery, followed by the posterior shoulder, for which we give gentle upward pressure on the fetal head, which can aid in the delivery of the posterior shoulder. The rest of the fetus typically follows with ease. During Stage 3, from delivery of the neonate to the placenta, there are a few key points. Immediately after delivery, we repair any lacerations of the vagina, whether they're first, second, third, or fourth degree. We also look for signs of placental separation in order to deliver the placenta. These include fresh bleeding from the vagina or bloody show, umbilical cord lengthening, the uterine fundus rising in the abdomen, and the uterus becoming firm. I'm going to review the operative deliveries, as the indications for these or the complications may show up on the Step 2 exam. The indications for an operative vaginal delivery involve both maternal indications and fetal indications. Examples of maternal indications involve maternal exhaustion with poor effort, or medical conditions such as cardiac disease which prohibits Valsalva, such as mitral stenosis. Some fetal indications involve the fetal head failing to rotate, or fetal distress with complete cervical dilation and adequate station. Complications with forceps deliveries involve maternal soft tissue injury or fetal laceration or bruising. Complications with vacuum deliveries involve maternal soft tissue injury, fetal scalp laceration, cephalohematoma, or subgaleal hematomas. Cesarean delivery are the most common operations in the United States. There are several different types which we've briefly discussed in the past, which include low transverse, classical, or low vertical. The low transverse is standard, whereas the classical is performed for preterm breech fetuses, inability to access the lower uterine segment, or when there's a planned cesarean hysterectomy in the setting of a placenta percreta. Low vertical incisions are used for preterm breeches. A few diagrams here reviewing the different types of uterine incisions Again, remember that these are uterine and not skin incisions. The low transverse, which is the most common type, seen here. The classical incision, used for preterm breech fetuses or inability to access the lower uterine segment, or at time of planned cesarean hysterectomy. And the low vertical incision for preterm breech fetuses. Remember that those who have a prior classical cesarean section always need to have a repeat cesarean section due to the increased risk of uterine rupture. I've discussed the indications for an induction of labor in other sections, and here I'll discuss how we go about doing it. Induction of labor is initiating labor via medical means. It can be done using various different types of medications. The first is prostaglandin E2 analog, or dinoprostone, which is used for cervical ripening. Next, prostaglandin E1, or misoprostol, has been used as an off-label medication for pre-induction cervical ripening. It's important to remember not to give prostaglandins to asthmatic patients, as it may provoke bronchospasms. The next is oxytocin. Oxytocin exaggerates normal uterine contractions. Recall it's normally found in the posterior pituitary, and the drug is a version of the naturally occurring substance. In addition to the medical means of inducing labor, we can also take advantage of the body's naturally produced prostaglandins by using mechanical means. The first is an amniotomy, which is an artificial puncture of the amniotic sac with an amnio hook. This releases the local prostaglandins at the side of the cervix. Next is a Foley balloon, which is blown up in the lower uterine segment and provides both mechanical advantages, such as pressure on the cervix, as well as the release of local prostaglandins. It's very important to inspect for evidence of a prolapsed umbilical cord after puncturing the amniotic sac, as the amniotic fluid flows out of the uterus.